very aggressive. And again, they're in sensory overload, so we just got to put them in a dark, quiet room, let them chill. And if they're still combative, then we're going to have to medicate them with benzos or antipsychotics. And there you see, no withdrawal either. We talked about inhalants. We talked about opiates. Let's talk about something that's not in the slides or the notes. K2 or spice, violence, hallucinations. Okay? Lots and lots of hallucinations and lots of violence. Typically marijuana alone, you don't see the violence. But the K2 and spice, you do see the violence mixed with the hallucinations. How do we differentiate? For marijuana, they'll give you the conjunctival injection. They'll give you the increased appetite. They'll give you the dry mouth. Because remember, marijuana typically is smoked. Young. This is cheap, so it's easier. K2 is a synthetic marijuana, not PCP. I mean, it's similar to PCP in the violence, but it's mostly the hallucinations. So it's usually young individuals that use this. Okay? Okay. And I think we're done with this chapter. Any questions? All right, let's go to the next chapter. The impulse control disorder chapters. And DSM-5 made several changes here. But yet tomorrow, please be patient with me tomorrow. I'll give you the list of how all these different things got moved around into different sections. Not so clear about flumazenil. Flumazenil is very rarely the correct answer, so be very careful. Does that make sense or no? Okay. Impulse control disorders, what you've got to understand here is what is the difference between an impulse. Now, we already talked about OCD, right? And what do we know about OCD? OCD, we know that you hate the fact that you do it. What it does is that it decreases. Okay, I left the stove on, I'm going to burn, my anxiety goes up. I check the stove, my anxiety goes down. So basically, what we have is that impulse and obsessions or compulsions are the same thing. The impulses are egosyntonic, okay? So these are things that people do that causes anxiety, and when you engage in them, your anxiety goes down. That's all you need to remember about these things. All right, so what are these different disorders? There are certain disorders that some of them are not here anymore. Some have been moved to other chapters, but it doesn't matter. Let's just go over them. Intermittent explosive disorder. Oh, by the way, let me give you good news. Low yield. What do I mean by low yield? Maybe you'll get one question, maybe two, but you're not going to get an overabundance of things, okay? So we're going to go over this chapter relatively quickly. Intermittent explosive disorder. The police recently arrested a 24-year-old psych inpatient after he beat up another patient, causing severe injury to the other patient's head and neck and requiring more than 100 stitches. When asked why he assaulted the other patient, he said, "He took my potato chip." This was actually a guy I had in New York. So you did something, and this guy reacted out of proportion. That's what intermittent explosive disorder is all about. Okay, so you are reacting. So these are individuals who are unable to resist aggressive impulses, and the aggressive act is always out of proportion to the stressor. An example of this might be road rage, right? How many of you have had road rage? Raise your hands. You get angry with someone. How many of you honk the horn? How many of you curse them? How many of you give him the finger? Okay. Now, maybe some of you out there follow him. And when you're at a red light, you grab him, you get out of your car, you get out of his car, you grab him by the neck, you beat him with a bat until he dies. That's intermittent explosive disorder. Okay, so it's always out of proportion, right? Even though it's things we want to do, we don't do them. So what do we need to know about this? These questions are always diagnoses. Do you know why? Because there's no FDA-approved treatment for it. So if there's no FDA treatment for it, guess what? It won't be asked on your exam. There's no drug out there that says, this is a drug for intermittent explosive disorder. You don't see it in an ad or anything. So all of these things are pure diagnoses. So they're going to give you a situation where someone reacts over the top, okay? And because it's violence, men, probably genetic. Because you're out of reacting, you probably have poor work histories, problems with your spouse, and maybe problems with the law. Look at all the treatments that we use. None is FDA, so guess what? No questions on the exam. That's the beauty. So it'll be a diagnosis, and that's it. You don't feel bad about what you've done. That's what makes it egosyntonic. Kleptomania. 25-year-old woman has a history of more than 20 arrests for stealing small items. She comes from a wealthy family and her parents do not understand her behavior. At home, she's got numerous salt and pepper shakers, napkin rings, ashtrays. So you steal things that you don't need. Now, if you're hungry and you steal food, don't call it kleptomania, call it hunger, all right? So these are people, you steal things like, you steal, I don't know, you steal this little clip I have here. Or you steal this, okay? So, do I need another pen? No, but I have anxiety. When I take it, I feel a lot better. That's what kleptomania is all about. It's more common in women. It can be associated with mood disorders, and especially with eating disorders. Patients who have bulimia have an increased incidence of kleptomania. This is a test question right there. All right, so be careful. Hunger mania. Oh, I like that. And again, no treatment. It's just a diagnosis. Pyromania, it's with fire. A 19-year-old mentally retarded boy is arrested after he's found setting the neighbor's garbage cans on fire. Neighbors have observed him starting fires, staring at them, and watching them burn. So this is an individual who starts fires for pleasure, and then it reduces his level of anxiety. Do not confuse it with arson, because arson equals money. You get money with this. People with bulimia have an increased risk for kleptomania. They think that what they steal is food. So there is an association with that. And that's been a popular question. So it's more common in men and nothing else. Again, we're not going to get into the... This one was removed from this chapter. It's just called gambling disorder, and it got put into the substance abuse. It got put into the alcohol and drug chapter. The last association, you mean eating disorders and kleptomania? that they have found that a certain percent of girls who have bulimia also have kleptomania. And what they steal is food. It is called, remember, I haven't changed the book to DSM-5 yet. All of these things have happened too quickly, and you know there's always a little backlag for the book to get fixed. So pathological gambling is now called gambling disorder, and it got removed from this chapter and it got put into the alcohol and drug chapter. Because do you remember the diagnoses of use disorder? It's the same thing. So when you have gambling disorder, the gambling takes your whole life. So Mike, pyromania is associated with nothing. Mike, a 40-year-old married man and father of 2, was fired from his job because of embezzlement of company funds. He disappeared with the company payroll cash. When found, he did not have the money on him and admitted to losing it while gambling. His wife left him 2 months ago, and he has not seen his wife or children then. So here we have an individual whose life is taken over by the gambling, right? His home life, his work life, his social life, and you keep gambling. So that's what the pathological gambler used to be called, which is now just called gambling disorder. And again, how do we treat the alcoholic? They go to AA. How do we treat the gambler? They go to GA. So they'll either describe a gambler, ask you what the diagnosis is, and how to treat it. This one will have a treatment because you go to Gamblers Anonymous, okay? Now, how to differentiate all of these things from kleptomania? Let's go to the whiteboard. A lot of you are asking, how do I differentiate conduct disorder versus kleptomania versus pyromania? GA is Gambler Anonymous. So conduct disorder is a baby antisocial. They lie, they steal, they torture animals. If you're going to steal, you're not going to steal this. This is insignificant. This is what the kleptomaniac steals. What the conduct disorder will steal will be a $10,000 watch, will be the keys to your car, will be your diamond ring. So they steal things of value. That's the big difference, okay? The pyromaniac versus the conduct disorder. The conduct disorder can start a fire, but they'll probably start a fire to kill you. You're in the building, I'm going to burn it because I want you to die. The pyromania doesn't want you to die. All the pyromaniac wants is to burn the building. You have nothing to do with it. So that's going to be the difference. Correct. Intermittent explosive is that it occurs intermittently. It's not a lifelong pattern of it. You don't necessarily lie. You don't necessarily steal. You do have these violent outbursts, but they're not occurring all the time. Make sense? Correct. Does that make sense to everybody? Okay. And slide. Trichotillomania. Let me get in here. Hold on one second. Let me get some color. Mary, a 20-year-old woman, is rushed to the hospital after she complains of severe abdominal pain. She appears thin and withdrawn and is missing a lot of hair from both her scalp and eyebrows. Physical exam reveals an intestinal obstruction. What is wrong with Mary? Well, Mary's pulling the hair. That's what trichotillomania is. How many of you here twirl your hair? I mean, my hair's picked up because I need a haircut. And I don't like how it looks now, so it's easier to pick it up. But if my hair were down, what I do sometimes is I'll start twirling it, And what does the twirling do? It relieves your anxiety. So the same thing, instead of twirling it, they pull their hair. Some of them put it in their mouth to chew it, or accidentally swallow it, or intentionally swallow it. It's kind of gross, but they do it. Some people chew the hair. All right, so this is more common in women. So here you see how you have a nice, that could be a trichotillomania. Yeah, let's put a little hat on her. There, we gave her a hat. Kind of looks like a platypus, but pretend it's a hat. And again, none of this is going to appear. This is just a diagnosis question. So any questions on these things? Can little kids have trichotillomania? Anybody can have trichotillomania. All right, so I'll see you in 10. And when we come back, we'll go to the next chapter, which is a chapter on eating disorders. Hello, everybody. Can everybody hear me or see me? Any questions from anything we have done so far? All right, then. So let's begin with the eating disorders. Let me get some color here. Hold on. Let's pick red. Let's do something different. High yield, right? You know, this definitely comes out on the exam, right? Everybody agrees? You know that they will ask questions on eating disorders. Okay, excellent. So when we're looking at eating disorders, we've got anorexia, we've got bulimia, and we've got another one that was added in DSM-5, which I'm going to go over in a little bit. So when we're talking about eating disorders, and I need to go to the whiteboard for a second, what is the goal of the girl who has anorexia? When we think of the goal of these girls is to do what? Reduce weight, right? The girl who has anorexia wants to lose weight. The girl who has bulimia wants to lose weight. So what are the ways that people lose weight? They diet. They exercise. They fast. They abuse laxatives. They abuse diuretics. And of course, they purge. So what you need to focus on is not the behaviors, because both the girls with anorexia and the girls with bulimia will diet, will exercise, will fast, will abuse laxatives, will abuse diuretics, and will purge. What happens to a lot of you is that you hear the word bulimia nervosa and you automatically think binge and purge. And you assume that everyone who has bulimia purges, and that's not the case. You can be a bulimic and not purge whatsoever. So if you are a bulimic that doesn't purge, then you don't have the typical physical characteristics of the individuals that purge. And that's where you can get a lot of these questions wrong. So for example, if you see binging and purging, how many of you automatically pick A, bulimia, or B, anorexia? A lot of you see this and go straight to that. But I want you to understand that it can occur in both of them. So don't focus on the behavior. We're going to focus on other things, okay? Good. So let's go to the slides. What do we know about the people who have anorexia nervosa? For you to have the diagnoses of anorexia, what you need is, let me get some color, hold on. You're going to have problems maintaining your body weight. That means that you are going to lose more than 15 to 20% of what's considered ideal body weight. If we're looking at the BMI, your BMI tends to be less than 17. So that is essentially what you need. You're worried about gaining weight. You have what's called body image disturbance. So body image disturbance is where you believe that you are overweight, but you are not. So you have a distorted sense of what you look like. So what does that mean? You might look like this, but what you see reflecting in the mirror is that, okay? So you see this as what you look like. That's body image disturbance. That's unique for anorexia. Amenorrhea got removed from DSM-5, so you do not need the amenorrhea anymore. So that is not going to be something that you have to look for in these questions to determine whether or not the girl has anorexia. So what is essential is the body image disturbance, okay, and the weight loss. So here we have a woman who obviously has anorexia, and this is here so that you see that there are two types of anorexia. There's a restricting type and there's the binge purging type. This is not going to appear on the exam. All that's going to appear is this, period. They're not going to ask you what type. I put that in there so you can see that there are anorexics that binge and purge. So what do we find? Look at that. Look at that. Look at this. Okay? What causes anorexia? Well, it could be genetic. And if it is genetic, then would we find more of it in concordance studies when we look at monozygotic twins? Yes, we do. What about psychodynamic issues? What could cause it? Well, they think that anorexia has to do with issues of control. That's what it is. These are girls that are tired of being told what to do. So the only way they can exert their control is by starving, by not eating. So that's how they control it. So we're talking about issues of sexuality, issues with the family, and mostly issues with control. You see it more in girls than in boys. Yes, the main difference between anorexia and bulimia is the BMI. The bulimic girls have normal BMI, the anorexics do not. The average age is about 17. Let's keep going. So what do these girls do, or what do they look like? Well, they constantly will weigh themselves. They want to control their portions. They like to cook. They like to prepare food, but what do they not do that foodies like to do? They don't eat. They also prefer to eat alone, because if they eat alone, then they can serve themselves less food, and then they just hide food all over the house. So if you are the purging type, then you could vomit or abuse laxatives or diuretics. When you tell them that they are too thin, then of course they're going to deny it. So let's move on. One thing that you can find if you are a purger, this is if you are a purger, then you will see what's called the Russell signs, which are basically calluses or abrasions on the backside of the hands from putting your hands or fingers inside your mouth, rubbing against the teeth. So you will have cavities, you will have dental erosions, you will have parotid gland enlargement, you will have lanugo hair, you'll look emaciated, you'll have blood pressure changes, and what typically kills you is hypokalemia that causes you to have an arrhythmia and therefore death. So they'll have malnutrition, so you'll have anemias, elevated enzymes, abnormal electrolytes, especially potassium, low hormone levels. And how do we treat these girls? Basically, the best treatment is safety, right? So we want to make sure that they're not so emaciated that they're going to die. So you might have to put them in the hospital, but if they're an adult and they refuse, you cannot force them into the hospital. So you give them medications, and usually the SSRIs are given, not because they're depressed, but because the SSRIs, a common side effect, is weight gain. And that's what you want them to do. You want them to gain a little weight so they have less likely of a chance to die. Does everyone understand anorexia? Body image disturbance, incredibly low amounts of weight, Now, mirtazapine, I know you were taught in step 1 that mirtazapine is the drug of choice for anorexia. There is no drug of choice. So I don't want you to think that one drug is unique. So I would rather you learn that any antidepressant is equally effective. Why? Because they cause weight gain as a side effect. Why do they have peripheral? Because of the electrolyte issues, because of the etc. Okay. Now bulimia is different. Bulimia is a girl who basically was probably obese, right? So she starts off by being overweight, then she sort of loses the weight, but she engages in what is called, she engages in what is called a binge. And a binge is when you eat massive amounts of food very quickly, okay? So you eat 4 pizzas, and I don't mean 4 personal pan pizzas. I mean 4 extra large supreme pizzas. How would you feel after you've eaten all those 4 pizzas? Now, I'm sure all of us have had one too many slice, or one too many pieces of cake, or one too many pieces of anything, right? We've all done it. How do we feel about ourselves? You sort of loosen your skirt, or you loosen the button of your jeans, or you loosen your belt. Have you ever done anything like that? Right? You feel guilty, right? You feel kind of disgusted with what you've done, like, ugh, I can't believe I did that. What's unique to the bulimic is that they then engage in what's called a compensatory behavior. What is this compensatory behavior? This compensatory behavior is something that they do to get rid of the food. So what could it be? Well, if I eat 4 pizzas, then I'm going to exercise. I'm going to go to the gym, and I'm going to run 10 miles. Or, you know what? I'm going to fast the next 3 days. Or, I'm going to abuse laxatives so I can poop the pizza out. Or, I might even purge. So that's what's unique about the bulimics. They engage in the binge, and then that is followed with this compensatory behavior in order for you to get rid of the food. That's what bulimia nervosa is all about. How is bulimia different from anorexic? Bulimia is not as lethal. Bulimia is much more common, and bulimia, basically their weight is normal. Maybe a little bit above, maybe a little bit below, but it tends to hover around the normal. So they believe that if they don't look a certain way, they won't be popular, they won't get married, they won't get the job that they want. That's what bulimia is all about. Much more common than anorexia, still more common in girls than in boys. Bulimia more common in female athlete cheaters, like, could be common in anybody, but it's girls who have, they want to look a certain way. Can the borderlines be linked to bulimia? Yes, the borderlines can be linked to anything, and that's the best guessed answer for you, okay? So if they ever ask you a question on a personality disorder and you don't know what the answer is, always pick borderline. You know why? God, because they're linked to everything. Borderline's got their hands in everything. So that's a pretty good guess. Do the bulimics worry about calories? No, because the bulimics, what they'll do is that they will prefer to eat alone as well. Why? Because that way they can eat 4 pizzas. If I'm having dinner with you and I'm eating 4 humongous pizzas, you're going to say, WTF, what is wrong with this person? But if I'm eating by myself, I'll probably eat the 4 pizzas, but if I'm eating with you, I might eat 3 slices. And then I might do something, oh dear. I might do something. Oh, are we all back? I kind of moved the screen. Is everyone with me? Can everybody hear me and see me? So what they do is that they hide food in order to eat it later. So again, this one isn't really lethal, but the way to treat it again is with an SSRI. So you give them an SSRI because they think that can control the binge itself. Okay? So they could also binge and purge and do all kinds of things. And I've talked about all of these things already. So here we see the teeth. Notice how you have the dental erosion. So if you're a purger, what you'll find is that your teeth are basically worn down. I mean, this person's obviously wearing caps on the top teeth because those teeth are just too perfect. All right. And the treatment, remember, is just an SSRI. They think that it's linked to low levels of serotonin. Remember, that is a big old theory. So they think that that is why they are using them. Okay, let me go over a new disorder that is in DSM-5 that is not in the notes. There's a disorder that they added to the anorexia and bulimia, and because it's new, I could see them asking this. It's called the binge eating disorder. It is a new disorder in DSM-5. Well, what do you think this binge eating disorder is? Where you binge, but then you have no compensatory behavior. Okay? That's that. Now, come on. I know all of us do it. How many of you the night before the exam or the day before or the week before, are you overeating? We all do it. I mean, I'm as guilty as anybody else. But you have to have specific criteria. So you've got to do it like once a week for 3 months in a row. I mean, we don't do it like that. Okay? Now, and if you do it like that, then you might have the binge eating disorder. So all of us eat because of mood, because of anxiety, because of stress. But these individuals, it's not necessarily linked to the mood. You just eat because you eat. So you got to do it a lot. That's what binge eating disorder. How would you know the person isn't overeating because of ovulation? Because you don't ovulate all the time. This has to be like 1 time a week times 3 months. So you have to do it at least once a week. So every week you're doing it. If you're overeating because of the menses or ovulation, it's linked to certain times. You're not doing it all the time. This is all the time. This is at least once a week. Every week for at least 3 months. So I think this rules most of us out, right? Is that correct? Or we are all in denial. But I think it rules most of us out. Okay, let's move on. Let's go back to the slides. And we're done with the eating disorders. So if I could get the next chapter. So remember, how do I make the anorexia, the diagnosis of anorexia? Look for, as my mind goes blank as I tell you what to look for body image disturbance and look for the weight loss, either they will give you the BMI or they'll give you the height and weight. Let me go over something you might not know, which is the one they eat what they think are easily digestible foods. Can it be just exclusive for desserts? Yeah, you can eat whatever you want. Binge eating disorder, again in girls relatively young. So if you're a girl and you're 5 feet, you should weigh roughly 100 pounds. Every inch over, you should add 5 pounds. If you're a male and you're 5 feet, you should weigh 106 pounds. Every inch over, then you add 6 pounds, okay? So this is a rough estimate in case they give you height and they give you weight. So it's when you lose 15 to 20% of this that you would say is the anorexia nervosa. Okay, so you got to lose BMI like 17, 18 and below is what we're talking about. So for you to have anorexia, this loss is going to be greater than 15 to 20%. So for example, if you're a female and you are 5'3" and you weigh 80 pounds, is that a weight for anorexia? Yes, because how much should you weigh? You should weigh 115. So that means that you are over that 15 to 20% mark. Okay? Does this make sense to everybody? So anorexia, remember, decreased weight and body image disturbance. Bulimia has normal weight. And this is how you differentiate one from the other. Anorexia is removed. So anorexia is not part of the picture. All right, let's go back to the slides. No body image in bulimia nervosa. Personality disorders, what do you think? High or low? Super high. Star, star, star. They love this stuff. And they still ask it on step 3 too. Yeah, sky high. Okay, let's move on. Let's start with what on earth is a personality disorder? Well, they're nothing more than maladaptive patterns of behavior. So what does that mean? These are things that I do that drive all of you crazy. These are things that I do that for me they're normal. So for me, I am okay with them. So if I'm okay with them, this is what is called ego-syntonic. I don't think I have a problem. It's you who has a problem. So this is me and my patterns of behavior. There are 3 clusters in these personality disorders. Cluster 1, cluster 2, and cluster 3. Well, actually, let me rephrase that. They're not called cluster 1, 2, and 3. They're called clusters A, B. So cluster A is the strange one, and that is why cluster A is called the odd and eccentric type. So everyone there, I mean, with that name itself, everyone in there is kind of strange. Cluster B is the nervous type. Is the dramatic and emotional type, and that is why cluster B is called dramatic and emotional type. And cluster C is the anxious type. And that's the one that is the worrier. So know the name of the cluster and know what's in the cluster. So what causes personality disorders? Are we born this way, like Lady Gaga says, or do we become this way? Or is it a combination of the both? I don't know. I think it's probably a little bit of something that develops into something else. Maybe what we've been through in our lives, what we're exposed to, watching our parents. They're not going to ask you what causes this. That's just, you know, I'm giving you some background. Now, when we look at prevalence, when we look at personality disorders, it's normal to have a little bit of everything. I'm sure that some of you have a little bit of OCPD, some of you are a little bit histrionic, some of you are a little bit antisocial, some of you might be a little bit avoidant, and that is perfectly normal. There's nothing wrong with that. When we look at the diagnoses per se, men tend to be, their diagnoses somewhat are biased, so you might see more of them being diagnosed as antisocial and narcissist, whereas women might be more diagnosed with borderline and histrionic. We try to wait before we give someone a diagnosis. We don't want to give a teenager a diagnosis unless we truly mean it. Because sometimes kids change, adolescents change, things can change a lot of times. But there's only one where we must wait. What do you think that is? Which is the only one where you have to be 18 before you give them the diagnoses? Conduct disorder, exactly. So the antisocial personality disorder is the only one where you have to wait until you are 18 years of age. Then you can give them the diagnoses, because if not, you cannot call them that. So when they're under 18, they're conduct. Once you turn 18, then you're called antisocial. Good. So what happens to people who have personality disorders? Well, think about it. Your life is going to be chaotic, right? So you're going to have chaos at work, chaos at home, chaos in relationships. You function, but you kind of function in a dysfunctional way. The treatment for the exam is always psychotherapy. Can meds be used? Meds are always used, but please remember, when I give a patient who's got borderline personality a mood stabilizer, I'm not treating the borderline. I'm treating the mood symptoms that go along with the borderline. So for the personality disorder itself, the only treatment on your exam is going to be psychotherapy. The change has to come from within. Does that make sense to everybody? No, they don't all require age 18. You should wait till you're age 18, but you don't have to wait. Does that make sense? So you should wait, but you don't have to. Okay, good. Let's move on. So let's review. Wow, this is tiny. This is how I know I'm getting older. When the new glasses don't work anymore. All right. So let's review each one and figure out what it is. A 57-year-old man lives in a condo complex and constantly, so you all think it's small, right? Good. It's not just me. So a 57-year-old man living in a condo complex constantly accuses his neighbors of plotting to avoid payment of their share of maintenance. He writes angry letters to other owners and has initiated several lawsuits. He lives alone and does not socialize. So what's the theme here? The theme is suspicion. You know, people are doing things, and they're doing things, I'm paying, they're not. So that's what is the theme of the paranoid personality disorder. What was their main defense mechanism? Projection. So they believe that others talk about them. They believe that others do things to them. They're already suspicious. They question the loyalty of family, of friends. They get in the cab. They think the cab takes the longest route. When they buy something at the deli, they think that they got gypped, and it's not half a pound of cheese. It's a sliver under half a pound. So these are the things that is typical of the paranoid personality. Do they have auditory hallucinations? No. Do they have visual hallucinations? No. Do they have delusions? No. So even though they're using the word paranoid, they are not psychotic. So please remember that. These are people that function and are not experiencing these sensations. Are we okay with this? Can I move on? All right, let's move on. A 24-year-old man lives alone and works night as a security guard. What if someone has been through a severe situation where people broke their trust throughout their life and engaged up and each as a diagnosis is made? Then it is really maladaptive? I mean, if someone burned you, then you should not trust. But you should trust somebody. The people with this personality disorder trust nobody. So it's nobody what they trust. So if it's something that happened in your life, then that might be an exclusion for this. Okay, does that make sense? Because people who are paranoid are kind of born paranoid. All right, let's move on. 24-year-old man lives alone and works nights as a security guard. He ignores invitations from coworkers to socialize, and he has no outside interests. Oh, he is just a loner, right? He enjoys being alone. So what do we call those people that enjoy being alone? The schizoid personality disorder. The schizoid likes being alone, goes on vacations alone, goes to the movies alone, eats at restaurants alone. And if you say something to them, they'll say, I don't care. I don't care what you think about me. I enjoy being by myself. And this is how you differentiate the schizoid from the avoidant. The avoidant has few friends. The avoidant has a few relationships. Why? Because they're afraid that if they get close to someone, they're going to be rejected. Whereas the schizoid doesn't care less. So that's why they're happy being alone. Does that make sense? Exactly, exactly. The schizoid likes it, exactly. Good, everyone's on the same page. Like night watchmen, maybe researchers working with rats. No, oh, where did my rat go? Researchers working with rats. I'm telling you, she keeps leaving this thinking that I'm going to scream every single time. You watch. I'm going to see a rat one day, a real one, and I'm going to think it's the toy, and then I'm really going to scream. Does this disorder need treatment? No. You only need treatment if it affects you, which rarely it won't. Then we go to the next one. A 30-year-old man is completely preoccupied with the study and brewing of herbal teas. Oh, this. Looks real, right? A 30-year-old man is completely preoccupied with the study and brewing of herbal teas. He associates many peculiar powers with such infusions and says that plants sometimes whisper to him. He spends all of his time alone, often taking solitary walks in the wilderness for days at a time, collecting plants for teas. He has no history of disorganized behavior. If there was such a thing as a weirdo meter, ooh, we are a weirdo meter. then this person would be right there, all right? You went all the way over to the other end. So this is someone who is definitely over the top. So this is someone who basically has what is called ideas of reference. So that's the belief that you're being talked about by others. So they'll say, like, you know, every song that I hear on the radio is about me. Everything I read on the newspaper is about me. I was watching the news last night, and they were talking about, even though they were talking about Putin and the Ukraine and everything, they're talking about, that's what ideas of reference is all about, okay? They have what's called magical thinking. Magical thinking. How many rings does it take for a person to realize that no one is going to pick up the phone? What do you think? How many rings do you give people? 2, 3? Exactly. Well, whoever's calling me doesn't get it. So magical thinking is when you believe that certain things have special powers. Like, how many of you have a lucky rabbit's foot? Have a lucky pencil? Have a lucky hat? That's magical thinking, when you believe certain things have special powers. People who are schizotypal have that. They talk weird, they look weird, they dress weird. How weird are they? Well, they're so weird that they can become psychotic, except once they become psychotic, they basically compensate. Oh, Walmart at night. Have any of you Googled pictures of people that shop at Walmart? If you've never Googled it, go and do that. After class, if you want to laugh, Google it. So you will see the strangest things. When I'm bored, I sometimes will do that. Okay, so let's see, the world is divided into two, right? Those that are normal and those that are psychotic. So this is us here. La, la, la. We're loving life. I'm way over here. And guess what? The schizotypals are right here. They got their feet over the edge. And if stressed, what do you think happens? They fall over. But there's this little branch that they hold on to. And then very slowly they climb back up. So they're kind of teetering on the edge between what's normal and what's not normal. So they're not always psychotic, but they can be. They're just very, very strange. Make sense? Okay. So was Sherlock schizotypal? Sherlock. Who is Sherlock? Sherlock. Oh, Sherlock Holmes. Oh God, I haven't read Sherlock Holmes in years. You mean the TV show? I don't know. I haven't really seen it. I don't see Sherlock Holmes as being schizotypal. He's weird, but I think these people are weirder. All right? A 30-year-old presents to the doctor's office dressed in a sexually seductive manner and insists that the doctor comment on her appearance. When the doctor refuses to do so, she becomes upset. Oh my goodness, we all know who this is, right? This is the histrionical. They're exaggerated, they're over the top. They love to be the center of attention. And if they are not the center of attention, they are unhappy. I think Lady Gaga is definitely histrionic, right? Who goes on into stage in an egg and then she pops out of the egg? Good God. I think that is definitely very histrionic. Spanish soap operas are very, very histrionic, okay? Not the men. Well, the men can be too, but the women definitely take the cake. So you see the drama factor? That's what this is all about. How many Hispanics out there? Where are the Hispanics? Yeah, there's a lot of us out here. I've been accused of being histrionic at times, but I can tone it down. It comes out when it has to. A 20-year-old a 20-year-old nurse was recently admitted after reporting auditory hallucinations which have occurred during the last few days. She reports marriage difficulties and believes her husband is to blame for the problem. She's got scars on her wrists and has a history of substance abuse.